Good evening, everyone. I am Arpita, the moderator for today's session from the IGCP group. It's my absolute pleasure to welcome you all to this insightful session on the topic Anemia in Expectant Mothers True Cases and Game Changing Solutions. We are honored to have with us Professor Dr. Madhulata Alexander, ma'am, a distinguished expert in obstetrics and gynecology and a professor at Osmania Medical College, Hyderabad. With a vast experience and deep understanding of maternal health, she will be shedding light on real life cases and innovative solutions in the management of anemia during pregnancy. Anemia remains a critical concern in maternal care, impacting both mother and their babies. A big thank you, ma'am, for joining in. And without doing a further ado, I would now request ma'am to please start with the topic for today. Over to you, ma'am.
Yeah, thank you, Arpita, for this kind introduction. Now, anemia in pregnancy is very common. In spite of all the measures being taken by the government, it is still common. But I can say one thing: India has come a long way in management and treatment of anemia. Today, as I discuss about this, a few case scenarios, I wish to bring you some modern innovations. I won't be talking about the run of the mill things that all PGs know, but I will highlight certain points that we already know because their place will always be there. Okay, I've also taken a few real case discussions which will help to make the talk more interesting. What exactly is iron and what is the role of iron in our body? The iron in the hemoglobin carries oxygen to the tissues, we all know that. And the iron in myoglobin helps supply oxygen to the muscle. Iron in the enzymes assists in biochemical reactions. Anemia is a silent killer, isn't it? We all know that. In spite of, as I told you, in spite of all the taken by the government of India, anemia prevalence is about 55 to 95%. It's a direct cause in 20% of maternal deaths and associated in 17 to 46% of maternal deaths. I work in the public sector, and every month we go to maternal mortality, not only in our hospital but throughout the state. Anemia still plays a role in the role of maternal mortality in many deaths in Telangana. What are the implications of iron deficiency? It damages the immune mechanisms and associated with increased morbidity rates. It's associated with adverse outcomes for both mother and infant, and it also impairs the cognitive development in children and causes loss of healthy life years. Now, what are the normal values? Before we go on to abnormal values, we should know what is normal. And by definition, throughout the world, it's about 12 to 13 grams percent in all women. The WHO has defined anemia as less than 11 grams percent, but the Indian government and the ICMR have defined anemia as less than 10 percent. Mild is between 8 to 10, moderate 6.5 to 7.9, and severe less than 6.5 grams. Now, recently they've introduced this very severe group that's less than 4 grams percent, which has to be managed on an emergency basis any time in pregnancy. Now, the first case is a common case which we all see in our OP. A 25-year-old G2P1L1 at 28 weeks, she presents to the OPD with the following symptoms. She has pallor, fatigue and weakness and penile edema. Probably fatigue and weakness are the most common symptoms with which anemic patients have presented to us. Now, what happens is, I won't ask for the other routine run-of-the-mill symptoms, but the main thing what I want to highlight is you must ask for a few of these. That is, any other bleeding sources, any sign of infection, passage of worms in stool. Now, what I'd like to assess is also we must not forget the drug history. Nowadays, many patients are anti-epileptics, anti-neoplastic drugs. These drugs, including hyperthyroidism, those drugs also are causing anemia. So it's very proper that we go into a proper drug history when we see these patients in OPD. Alcohol is very common. It is also being consumed by young expectant mothers, and we should go into this history because alcohol will cause folate acid deficiency, which will be megaloblastic anemia. The most common anemia is not only iron deficiency, it's also nutritional anemia, which includes iron deficiency, folic acid deficiency, megaloblastic anemia. That is vitamin B12. What's examination? You must examine the patient from top to toe. Look at the whole body. Do a BMI. When you detect the BMI, when we calculate, because we have to calculate a lot of things depending on the BMI, we have to look at the pre-pregnancy BMI. Pallor should be looked. Another thing is you should also look for edema all over the body and nails. Don't forget to look at the nails because platynychia, koilonychia, and longitudinal ridges are a sign of severe chronic anemia. Eyes look for pallor, and hemolytic anemia says a pearly white sclera and lemon tinted sclera. The hair also will be lusterless and dry with hypopigmentation. The tongue also, the mouth will give us a lot of information. It will be pale, and in addition, it will be bald and pale, beefy red of niacin, and magenta of riboflavin. So look for other signs of nutritional deficiency. Bony tenderness is not common. It may occur only in cases of leukemia. We are not very seeing it. But me being in a public sector, in a government hospital where we have more than 25,000 deliveries a year, we do see sometimes these cases because they refer to us. Also look at the JVP, the EM, and main thing, look for other masses. Look for the breast, thyroid. Thyroid is very important when you look at general examination. What are the aims of investigation? Whenever a patient presents to you, what do you aim for? You have to confirm the diagnosis of anemia. What is the kind of anemia? What is the cause of the anemia? In pregnant women, we also have to see the severity, type, gestational age, any associated obstetric complications, or any anemia associated complications. What are the investigations that are specific to anemia? Now, we do a lot of anemia at second, third, and now even fourth visit. It has to be done, the complete blood picture has to be done on booking. Its first week is done at 28 weeks, 36 weeks, and 28, 32, 36. This is what is recommended. Peripheral smear, stool ones, the complete urine examination, fundus. Peripheral smear will give us a myriad of information. That is, gives us information about malaria, any sickling, any thal, etc. The liver function and renal function tests are very important, and thal screening is done in high altitudes in risk patients. Luckily for us, nowadays we're doing the HPLC, the hematoelectrophoresis, as a routine, even in government hospitals, so that we are not missing these rare kinds of high hemoglobinopathies. Now, what I have got these charts from the Tamil Nadu government, put this in all the peripheral hospitals. That is, they first estimate the patient's blood at 14 to 16 weeks, and then they divide the patient into less than 7, 7 to 10, and 10 to 10.9. Less than 7, they straight away refer the patient to higher centers for. Now, the other one that is 7.9, 7 to the one that is a little lower, the 7 to 10.9. What they're doing now is they are giving either parenteral iron, which I'll come to later, or therapeutic iron, that's about 100 mg of elemental iron, along with folic acid and vitamin B12. Above 11, they are just giving only the preventive aspect. That's only they're giving 100 milligrams of elemental iron. All these slides, this one, the following one. Now, what is happening is after 7, people are giving IV sucrose, which has got a lot of advantages compared to oral. We are more certain of the hemoglobin rising. Okay, and the other one we're doing the test done between 26 to 30, and either you decide if the patient needs iron or continue therapeutic. You are still justified in giving oral or IV parenteral iron when you at this point. Now, main thing when you should advise the patient is you cannot give oral and IV iron at the same time, because as you know, the main reason being the receptors will be blocked, and also the other problem is if you give the iron, it will be anaphylaxis. So you have to choose your patients well. And nowadays, what is happening is we're giving most of the time in our hospitals, government, after this Anemia Book Bharat, we are having access to good, to all this IV sucrose and FCM. So we are giving them to pregnant patients and postnatal patients, which goes to treating anemia in a big way. Now, the other case I'm discussing is one Mrs. S. She wants to have, she's not pregnant now. She wants to have a healthy, non-anemic child. Something family must have told her that is some friend must have had an anemic child. So she has come to us for counseling. What advice will you give her? The main thing is what you will give her is what advice you give her is plan her pregnancy. In between two pregnancies, have at least a 2 year gap. See that the hemoglobin is built up. And also, if she's anemic, treat her. Preferably, oral iron is given depending on the severity. Now, if she's pregnant, what do we do? How do we manage the anti period? If there is no complication, as I told you, we just give orals. We have to give proper dietary advice. That is, ask them to eat iron-rich foods, cook in cast iron vessels, and also take the iron tablets before breakfast. Do not take it along with the calcium. Calcium should be given later. Okay, and do not take substances like tannins, etc., which may cause impedance of the iron absorption. Deworming now has become mandatory, and all ASHA workers are giving all patients a course of deworming. Parenteral iron is given now most commonly, as I will be coming to, and more than 36 weeks. If the anemia is severe, we give straight away, we give iron transfusion. We give RBC transfusions. Now, oral iron, as I told you, the government of India has recommended 120 to 180 milligram per day, out of which only 10 to 20% is absorbed. But in spite of all the tablets being given to our pregnant women, only 50 or only half of the mothers are seen to be consuming this. So somehow this oral iron has failed to get the desired results, either because of poor compliance, because as you know, anything given free, nobody is going to accept. Okay, or maybe only poor absorption, poor bioavailability, or uncertain response. Now, parental iron is giving popularity. It should be considered for all women with confirmed iron deficiency who fail to respond or who are intolerant. Some patients are intolerant of oral iron, so in these we can give it as first line. Iron was given long ago, but now we have abandoned it because of injection technique, Z technique, painful reactions, and discoloration. So now what we have done is we are doing IV iron therapy, overcomes all these hurdles. It elicits a five-fold erythropoietic response in normal individuals, rising in a hemoglobin rises in a few days. Okay, lot of positive points about IV parenteral iron. Now, iron sucrose complex, what is commonly used in pregnancy, we do not give the FCM, although certain studies are saying that we can give the ferric carbos maltose injections. But no, what we are recommending is iron sucrose complex or the oral valid first time option for the safe and rapid reversal of iron deficiency anemia. What should be emphasized is it is not greater or faster. The response to this IV parenteral iron is not greater or faster, it is more certain. So therefore, you are more certain of correcting the anemia. Okay, it's a brown sterile aqueous complex, about 20 milligram per ml, and ampules are available. Now, there are so many advantages of it. Low molecular weight, so there's no anaphylaxis. No biopolymers, so there's no anaphylaxis again. No preservatives, no test doses required. Taken up by the reticuloendothelial system, so the response is very rapid. It's not taken up by the liver, kidney, so this etc. Correction of anemia in pregnancy or restoring iron stores, especially because you can calculate the total dose of what is required, give it a divided dosage over 2 weeks, and it helps to correct the anemia. What are the reported side effects of this parenteral antibiotic, parenteral iron is the metastases. They may be pain, nausea, lethargy, facial flushing, and vasovagal attacks are common, uncommon, and anaphylactic shocks are very, very rare, about 3 to 4 per million per year. Okay, but we give it routinely in our hospital, and very, very rarely, maybe the last 6 months, we have only about one problem that we have to discontinue the parenteral injection. How much iron to give? I think all PGs is you have to calculate their deficit by the body weight in kilograms. This is pre-pregnancy weight into the hemoglobin deficit and grams as percentage 1.4. You have to add 500 milligrams for the stores. And this is given in divided doses over 2 weeks. Main thing is do not couple it with oral iron. If you're restarting oral iron, wait for about 8 to 10 days before you restart oral iron. This is very important. And if you see the iron sucrose response is as early as day 7, patients start feeling good. So they come back for the next doses. Many patients, they take it in the Basti Davakanas or the peripheral clinics, what the government of Telangana is running, and they're happy, they feel better. There's reticulocytosis, which is the early sign of iron, of response to iron therapy. is rise of hemoglobin and improvement in the indexes. Now, another case, this patient has just delivered and she had atonic PPH, she was managed very well in the hospital. Now, hemoglobin after that, when you check it after 2 days, is coming to 7 grams percent. How will you manage? What will you do? Will you rush in and will you give in blood? What will you do? What are the options that you have? You can either give her oral iron therapy for 3 months, but she must be very, very motivated. Patients after delivery are not so motivated to continue medications. Or you can give iron sucrose in 3 divided doses before she goes home. Or a better version is you give iron FCM, ferric carboxymaltose, which is given in a single dose. This responds very well. The response is almost certain, and the patient responds very well. Main thing is in the post-natal period when the patient immediately delivers, there's an erythropoietin state and so the erythropoiesis goes on at a very high rate. So IV iron supplementation increases the erythropoiesis 5 times. And the hemoglobin rise is seen as early as 5 days. So a good option will be giving at least one dose of FCM in the hospital. What we are doing to any anemic patients, anyone below 8, we're giving them one dose, sending them home. Very rarely they come back to us because they go back to wherever they deliver. And then we have seen the few patients who have come back are showing excellent results with FCM. IV sucrose is given. Sometimes, as I told you, many patients when they come back after 3 months, then they come back to us because they come back to us because either for the birth certificate or they want any postpartum, they want any contact advice. Then we check, we find that they are having good quality life because of the increased hemoglobin. Now, another question is, can the newborn of the mother be anemic? The mother is having good hemoglobin. She never was anemic. Why is her baby being anemic? Because sometimes vasa previa, the baby can bleed. There can be, in case there is TTTS, transfusion syndrome, hemolysis due to RH compatibility, and sometimes repeated bleeding. You take blood to the NICU, but I think this is a bit too much, or bleeding from hematoma or any intraventricular hemorrhage. This can also cause anemia in the newborn. Now, another case. The patient tells you she has anemia in her antenatal period in the previous pregnancy. Okay, her child seems to be having behavioral problems. Was there any connection? She's worried. Was there any connection to her anemia in pregnancy in her first pregnancy? She comes to you. What's happening now is many reports are coming where there are being cognitive problem. Iron deficiency is having a negative impact on the developing brain in infants. What I'd like to show these next few slides is probably we can educate our women that you're not anemic. Your baby is not going to have any cognitive problems. Okay, this can be another incentive for her to take supplementation. Synthesis. What does the iron help you? It helps in myelination, synthesis of DNA, neurotransmitters, incorporation in cytochromes of mitochondria for generating ATP, and in every cell it plays a very important role in the electron transport system. Iron deficiency in children also can cause much morbidity, infection, weakness, and failure to thrive. Neurocognitive dysfunction, that is thinking, reasoning, etc. This can also have a problem. Now, can iron supplementation, as I told you, my patient, correct this dysfunction? Before 2010, what would the evidence was saying? The damage is irreversible. Between 2010 and 2013, there was some evidence, but people wanted RCTs. But now what has happened now is after 2022, 2023, there seems to be some significant positive effect in giving children supplementive iron after delivery. That is, the babies who are, if you are supplementing them, there seems to be a positive effect on the cognitive functions. What are the various interventions you can do to improve the anemia in pregnancy? Antepartum, yes, as I already discussed, correct anemia at birth. Delayed cord clamping is very, very important. Even those few ml, especially in anemic mothers and babies, will help the baby in a long way. And in children, have to give good diet, good supplements, so probably at a 45 food, and also deworming will help. What are the pharmacological methods? 45 foods, supplements for children, weak iron supplements to adolescents. It has been given in our government schools, etc., and periodic deworming. Iron in the diet for the whole family is your responsibility because you give the whole family, provide it with iron for 5 years. without any gender discrimination. It lowers the carbon footprint, lowers the cost, and higher compliance. Now, I would like to end my slides with these. There's something new concept that has come out called patient blood management, PBM. What is this? What are people talking about? What is one management? It is a multidisciplinary approach that aims to reduce blood loss and improve patient outcomes. It can help to prevent anemia, reduce the need for transfusions, and improve clinical outcomes. What does it mean? What does PB mean, patient blood management? You take steps to minimize or avoid transfusions if possible. This is known as patient blood management. Who else can we target but a pregnant woman? Now, what is obstetrics? What is this PBM in obstetrics? What is it based on? Three main pillars. Optimize the blood cell mass by identifying and treating anemia pre-pregnancy. Minimizing blood loss during delivery. Manage anemia postpartum. How do we minimize blood loss during delivery? By the active management of third stage of labor. And managing anemia postpartum, including it doesn't only involve managing anemia, but also we have to avoid unnecessary blood transfusions because we know there are so many problems coming with blood transfusions. What are the benefits? The reduced patient morbidity and mortality, lowers the hospital cost, shorter length of stay, and improved pregnancy outcomes. So everybody's talking about this in a big way. How can you do it in pregnancy? Screen the patients for anemia and identify the risk factors for PPH. Treat anemia with iron supplements or preferably with IV iron. Blood transfusions use only when needed and only for people who accept them. Hemostasis is optimized hemostasis, reduce blood loss. How do you optimize blood loss during surgery? Use harmonic scalpels, precise tissue handling, and meticulous hemostasis. Tourniquets where appropriate, and position the patient correctly. And how do you optimize tissue oxygenation? By maintaining adequate blood pressure and using topical oxygen therapy or hyperbaric oxygen therapy. Now, somebody was saying that recently a lot of interest has been coming saying that even with 0%, 0 grams hemoglobin, they are able to maintain the patient by giving hyperbaric oxygen therapy. How do you manage anemia? Preoperative iron supplementation and administration of erythropoietin to stimulate the red blood cell production. To conclude, patient blood management is a new kid on the block to combat anemia in pregnancy. IV iron preparation show excellent results. So slowly we have to think more in terms of this, especially for non-compliant patients. And anemia correction can improve neurocognitive disorders in children and help them realize their potential. Thank you.
Thank you, ma'am. Thank you so much for this very insightful talk. Now, with your permission, can we take the questions from audience?
Yeah, sure.
Ma'am, the first question is how can the healthcare providers ensure better patient compliance with iron supplementation, especially in regions where adherence is a major concern?
See, I can tell you one thing. The government of India is doing a lot of effort and into eliminating anemia. Like, see, I am working, as I told you, in the government sector. Now, if a patient comes anemic to my hospital in problems, what happens is we go back to the grassroots. We take her patient, apart from treating her, we call the A&M who was in charge of her. We find out, we see when was her hemoglobin, when was she booked, when was why was iron given? Did the patient not take it? And why did the INM not see that she was referred in time? Why has she come with anemia and failure to our hospital? So there's a lot of follow-up for each and every pregnant woman in all the government sectors, not only in our hospital, all over India. And our Prime Minister is very fond of this Anemia Mukt Bharat. So many drugs are being given to us, which is reaching the population. There is food fortification going. Students are being checked in schools, especially young girls. Young girls are being given good diet. And every month, 4 times the hemoglobin is being estimated by for every pregnant woman. So I feel that lot has been done, but lot has to be done. At least it, as I told you, if the mother knows there's some cognitive problems in the child, tell the mother that nobody is more compliant than a pregnant mother for her children. She may not being mind being anemic, but if you tell her baby may have behavioral problems, 100% she's going to take the iron. So that's a good way of educating, spending time, and the government has realized it. There's almost like a one-to-one care is being given to each and every pregnant woman in the country. So although anemia is still prevalent, it has come down. And those terrible patients where we used to see, I told you we have so many deliveries a month. Before we used to see so many patients coming with 2 and 3 grams hemoglobin. Now it has come down to a large extent, I can tell you. Very few times we see such bad patients.
Right, ma'am. Ma'am, the next question is, in cases where blood transfusion is required for severe anemia, what key factor should be considered to minimize the risk both to mother and the baby?
See, blood transfusion, as I told you, we usually reserve it only for emergencies or any time after 36 weeks when the patient is going to deliver and a hemoglobin less than 7 grams. Before, what recommendation was below 7 grams anytime in pregnancy, give blood transfusion. No. Nowadays, only after 36 weeks, we are giving blood transfusions for patients. But there are specialized situations when we have to give, when the patient is in failure, or certain reasons we have to give blood transfusion. Okay, the main thing is almost all the blood banks are all monitored. They all are standardized. You cannot run a peripheral blood bank without following the proper protocols. So, and also there's a tie-up between various blood banks, not only I stay in the city capital, but also in the peripheries. There is a tie-up between all the blood banks. So if blood is not available, you get blood from other blood banks. Not only the public sector, you get it from private sector. There's a good network. The minute you put on that you want a particular blood, we are getting it. Another one thing that's good nowadays, we don't want whole blood for all patients. We are giving only blood products. So 1 unit of blood, whole blood can be used by so many different people. Okay. So that is why more blood is available for the right person at the right time.
Right, ma'am. The next question is, it's very obvious question, ma'am. Like the role of nutrition and lifestyle in preventing anemia during
Yeah.
pregnancy, and some practical dietary tips, like if you can share.
Yeah. See, what is happening now is everyone, whenever a patient comes, people go on telling, oh, I don't want drugs and all that. But iron is a drug you have to take. Okay. Now, what is happening now is we are advising patients to cook in cast iron vessels. Many rich patients also are now going back to those cast iron vessels. Okay. Now, even if you see this non-stick pans, nobody's cooking in them. So people are using iron things. What usually non-vegetarians is a good source of iron because we easily absorb it. Liver, proteins are easily absorbable. But vegetarians, their diet is deficient in iron. Even milk, for that example, cow's milk breast is deficient in iron. So these people should be counseled to have more. Like peanut toffee is a very good way for vegetarians to get iron, and they should be anyway. We are checking these patients periodically. So anytime with a deficit, counsel patients, give them more than one tablet, give them the option of IV iron. So that way it goes a long way. Diet is iron-rich foods, especially vegetarians. You should be more careful. Give them more in a thing like you say palak is supposed to have good iron, but you must eat kgs of it to get it. Is it possible? No. So these patients must be counseled more to take iron. Take it on an empty stomach. Do not consume tea with it. Take vitamin C. Usually they give vitamin C is given along with iron tablets to help in the absorption. Okay. All these small tips go a long way in the managing of iron deficiency anemia.
This was a very important one, ma'am, that taking iron empty stomach. Many of them, I'm very sure, did not know about it. Yeah, so
Mm.
yeah, thank you so much for that. Moving on to the next question,
And
ma'am.
you should
I'm a
not.
medical.
One more thing is, you should not consume iron along with calcium. Now we give our patients, when they're pregnant, iron, calcium. It should not be taken together because it affects the iron absorption. Do not take iron along with tea, tannins. All these retard iron absorption. So you have to take it along with vitamin C helps in iron absorption. Okay, orange juice, vitamin C, all these help in iron absorption.
Ma'am, there are some medicines which are a combination of iron and calcium,
No,
which
we don't take that.
okay, okay,
No,
ma'am,
they
okay.
should not be taken because iron and calcium should not be taken together. They should be taken separately. That's why we tell them calcium should be taken after meals, either after lunch or after dinner. It should not be consumed along with iron. All our ANMs and our ASHA workers, they tell the patients, they educate the patients about this. And
Right,
all our
right.
patients are Google doctors, isn't it? They all Google, they all know what to do. So patients are basically, and also as I already said, the most compliant patient is a pregnant patient. She'll do anything for a baby. Even if you tell her stand upside down and take a tablet, she will do it for her baby.
Right, right, ma'am. Ma'am, can you share any specific case where, like, a unconventional or a lesser known treatment approach significantly improved the case of an anemic mother?
Any woman. See, I work in a teaching institute, so we don't do any non-scientific things. Okay, I work in a government hospital in the most prestigious hospital in Hyderabad. So we follow
Right.
protocols. We don't do our own treatments. So what we don't do any unconventional treatment. We go by the book. Any recommendations, all those things, we only do it by the book. We don't do our own treatments. Okay, we don't do any unconventional thing. But I told you, the best is mothers will listen to us in pregnancy because every mother wants a healthy child. So this is the best time to catch mothers. What happens is after the delivery, they forgot, they go back to their own thing because their baby is most important. But uh, after delivery, also we must remember we must at least give iron and calcium for the next 3 months. Another thing, tip what is the social and preventive medicine, what they told us is the mother must eat along with the family members. She must eat. Then at least she will get her share of food, not after everyone eats. I believe in certain villages, the mother eats later. One very important point they said is she must eat on at the table along with family members to get at least a good proportion of healthy food.
Or maybe in some cases, the mother should have the food first and then the
First,
family they can have the rest.
will a
That
mother
would
ever
be
do
better.
that? My God. I don't think a mother will ever do that. Anyway.
Right, right, ma'am. Ma'am,
Hmm.
as you are in a government setup, so you must be relating more with that. That the population who come to you, they come in a much later phase of their pregnancy because they are not much educated. That they will come early stages. So in that case, does it happen that the anemia has come to a like very crucial stage, and then you have encountered that?
No, no. What I'm telling you is, I'm in Telangana, okay, where the system is very good. Every patient is booked like a pregnant. The minute you're pregnant, you're seen by somebody. So, and we have very many. We have about 32 government medical colleges. So everybody is seen. Only if they cannot manage in the pregnancy, they refer to us. The system of referral is very good. So we, as I told you, we don't get so many patients in failure. So many patients who are so anemic. We get the high risk patients who are having heart disease, or sometimes patients are missed. Probably the anemic patients nowadays we're getting 16 pregnancies who the people don't know they're pregnant. They're having illegal pregnancies. They come to us with anemia, but now they all these youngsters also protected by POXO Act. So everybody is getting good care. The minute anemia is there, we are able to correct because we are accessible to blood products. And as I told you, even rare groups, we get the groups available. And also we have nizams in our state. They advise us, supposing we are finding a difficulty in diagnosing some problem in pregnancy, the blood is not coming up. We have a lot of experts that we can refer to. Then they tell us how to manage. We have very good teams. Anesthesia, as soon as a crucial patient comes to our hospital, we get the anesthetist to check them out in case they go to labor when seniors are not there, how to manage. It's all written out for every patient, and a birth plan is given for all patients. So by losing a patient per se because of anemia, no, we do not do it. Sometimes because of PPH, post after delivery, sometimes patients bleed a lot. That also, there are so many ways to prevent it, but still we lose some patients sometimes. Okay, because of whatever reason we do. It's not like zero mortality, but it's very, very less compared to before. And I'm proud to say Telangana is the highest in third lowest, I must say, in maternal mortality in India. So we have very good statistics, and we look at other states, we look at the way they respond. I mean, they give there are government of India guidelines what to do, where to get help. A lot of medical care has improved in the last few decades. There's no doubt about that.
Right, ma'am.
And one more thing
Really
is,
appreciable.
finance also is not a problem. Finance also is not a problem. Any problem the government arranges for us. So those main things is, because you're poor and because you're inaccessible doesn't mean you will not get good care. You get the best care in government hospitals. And even our Prime Minister, our Honorable Prime Minister is very particular. He has launched Anemia Mukt Bharat. So many drugs we are getting because of that. So we are always grateful to the system. It is working.
Right, ma'am. Very nice to hear that. Thank you so much. Ma'am, there's one more question that is how do different types of anemia, like the iron deficiency anemia, the megaloblastic anemia, so impact different pregnancy differently, and how should the treatment be tailored accordingly?
Yeah, see, basically, what I like to tell you is most of the anemias in India are nutritional, okay? Mainly because of iron deficiency. So basically, we give off a blanket rule. We give off iron, we give folic acid, vitamin C, and vitamin B12. Now, if they have other anemias, they have to be treated. What we do is we have hematologists with us, okay? We get them properly diagnosed. Diagnosis must be important because if a patient has something called thalassemia and all, I told you, are being diagnosed early because of the electrophoresis, sickle cell diseases and pains. That there are ways to manage them, and these are done in hospitals like ours. Okay, so whatever, if you are only blood deficient, you manage differently. If you have any problem, immediately you are sent to a higher center. You are evaluated, and your birth plan is already done. So there will not be any delay. It will all be written in your case sheet. You will be told what to do. Okay, so each patient is tailored for each problem. Okay.
Right, ma'am. One last question for today. That is, what are the latest advancement in iron supplementation and alternative therapies for managing anemia in expectant mothers?
See, I told you about the patient management, isn't it? Patient budget management. This is very important because we correct the patients in in the antenatal period, so that after delivery you are able to we are able to minimize. Before, we just used to push blood into a patient. No, that is not the concept nowadays. We are only giving blood products to the minimum, and we are educating patients. We are seeing methods. As I told you, patient blood management is being done so that we reduce the amount of blood transfusions going on, because even blood transfusion has its own negative points. Okay, so all these things, there's a lot of things going on, and there's a lot of advancements, and we are also pushing from the government so many other things. Okay, as I told you, everything is being done, and every case, like, you just cannot uh, every case we see every particular thing, proper diagnosis. And even in government hospitals we are giving one-to-one counseling, so hopefully there will not be any problems.
Right, ma'am. So that was the last question, and with that, we would like to conclude. But, ma'am, before that, a big thank you to you for your invaluable insights on anemia and expectant mothers and your expertise and real world case discussion. The way you have conducted it has provided us with like deeper understanding of the challenges and the solutions that have come across in maternal care. So, thank you so much, ma'am, for putting all your
Okay.
effort and your time, and thanks to all our attendees for your participation and engaging question. So in this way, if we can continue the sessions, maybe if one or two person are also benefited, that will be great for all of us. So with that, ma'am, thank you. Thank you so much for your time.
Thank
Thank you.
Yeah. Thank you, Akta.
Thank you.